know about you guys, but I could listen to Dr. Bramlage all day. That was very interesting. Thank you, Dr. Bramlage. We have a 15-minute break, so take a break, come back, 15 minutes. We'll get started again at 3:30. We'd like to go ahead and get started. If you could please make your way back into the sales pavilion and stop talking in the corridors. About the what? Oh, I didn't either until they pointed them out to me. Yeah, and I was like, no wonder you can hear it when you're out there. Yeah. Yeah, because I always, I just thought there were speakers out there. But it's that, yeah. But I guess it's, and there might be some, but. Yeah, yeah, I think there are speakers. True. Yeah. Okay, we're going to go ahead and get started. So if you are still out in the corridor, if you could just keep your conversation low or move to the Northern Dancer Bar, which is way off to the left there, so we don't pick up your conversation in the sales pavilion. At this point, we're going to have a panel to discuss and inform on proper diagnosis. These are lessons learned from post-mortem programs. You know, and I have to say, none of us wants to see a breakdown, especially a fatal breakdown, but post-mortem examinations have revealed some illuminating information, and we're going to have Dr. Mary Scollay to moderate this panel. And I have to say, I've known Dr. Scollay for a very long time. I knew her when she was an on-track veterinarian at Arlington Park, and she's been hands-on and proactive in trying to reduce and minimize breakdowns in all the years that I've known her. She's a 1984 graduate of the University of Illinois College of Veterinary Medicine. Dr. Scollay served for 20 years as an on-track racing regulatory veterinarian before becoming the equine medical director of the Kentucky Horse Racing Commission in 2008. She is an active member of the American Association of Equine Practitioners and has served the organization in a broad range of roles. She currently serves as the AAEP's Racing Committee and Professional Conduct and Ethics Committee. She is a member of the Racing Commissioners International Regulatory Veterinarians Committee, the International Group of Specialty Racing Veterinarians, and an associate member of the European Horse Racing Scientific Liaison Committee. She is a board member of the Racing and Medication Testing Consortium and is seated on its Scientific Advisory Committee. She is also a board member of the Racing Surfaces Testing Laboratory and serves as a veterinary consultant to the Jockey Club Equine Injury Database. Dr. Mary Scollay.
I'm going to go ahead and invite our entire panel to come up here at once. We're going to sit together, and although we have individual presentations, it'll give us an opportunity to have comment and feedback within the group. So come on up, group. Now on? Yes. Okay. Seated to my left, we have Dr. Laura Kennedy. Dr. Kennedy is a native of Michigan. She attended Michigan State University, earning a Bachelor of Science in Animal Science in 1997 and her doctorate in veterinary medicine in 2001. Following graduation, she spent 2 years as a breeding farm veterinarian for a large commercial standardbred farm in Pennsylvania. Having decided in her senior year of veterinary school she would like to pursue a career in anatomic pathology after gaining clinical experience, Dr. Kennedy attended Texas A&M University, completing her residency and achieving board certification in 2006, followed by a fellowship at the Texas Veterinary Diagnostic Laboratory in Amarillo. Since the summer of 2008, Dr. Kennedy has been a faculty member at the University of Kentucky Veterinary Diagnostic Laboratory and has been involved in Kentucky's racing necropsy program since its inception in 2009, both performing the examinations and presenting her findings in various professional and regional and national settings. To Dr. Kennedy's left is Dan Fick. Currently the track steward at Prairie Meadows, Dan has nearly 40 years of experience in the horse racing industry. As AQHA Director of Racing, Dan helped start the Stewards Accreditation School at the Arizona Racetrack Industry Program, of which he is an alumnus. While Executive Director at the Jockey Club, Dan was part of the team that established the Racing Officials Accreditation Program. Dan lives in Granbury, Texas. Welcome, Dan. To Dan's left is Dr. Megan Romano. She is a commissioned veterinarian with the Kentucky Horse Racing Commission. Dr. Romano attended the University of Florida College of Veterinary Medicine and completed a hospital internship at Root and Riddle Equine Hospital before entering private racetrack practice based in Lexington, Kentucky. Her regulatory career began with a position as examining veterinarian for the New York Racing Association. In 2012, she returned to Kentucky to continue regulatory work in her current position with the Kentucky Horse Racing Commission. I took a few liberties with our assignment because we're going to talk about necropsies, but we're going to talk about some other information that can be factored in and considered when identifying horses at risk or identifying opportunities to intervene and prevent injuries. So going back to 2006 at the Welfare and Safety Summit, Dr. Bramlage issued this challenge: reduce the occurrence of racing fatalities by 50% in 10 years. Doing the math, we're 8 years in, and according to Tim Parkin, we have not moved the needle very far on a North American basis. I use this slide a lot, and it just reminds us where North America sits in comparison to the rest of the world with respect to the occurrence of racing fatalities, and we do not compare favorably. A 50% reduction in racing fatalities would, in fact, bring us back in alignment with the international community, and our stewardship of the horse would not come under the question that it has been to date. In order to achieve this reduction, what we're really talking about is better protecting just one more horse out of every 1,000 starts. That shouldn't be an insurmountable goal. Locally, we've been working very aggressively to reduce our injury occurrence, and while not statistically significant, tip of the hat to Tim, who's taught me to be very careful about that, you can see that we have a very positive trend. Our injury occurrence has reduced consistently over time. In 2008, shortly after I arrived, we began jogging horses at the pre-race exam, and from there we have added expanded pre-race exam protocols that Dr. Romano is going to discuss, and in June of 2014, we adopted 24 of the 26 National Uniform Medication protocols. And to enhance or remind you what Tim said this morning, the importance of local data. He has given us an awful lot of information about risk factors based on the composite of the North American information, but we've also spent a lot of time looking locally at our own particular risk factors and finding ways for interventions that are effective within our population. And I encourage everyone out there to both rely on his work and continue to be curious and investigate your own situations to find strategies that are effective in your locale. To date, the pre-race exam has been central to regulatory efforts to prevent injuries. The pre-race exam, and I discussed this last year, has been effective in identifying horses for which withdrawal is warranted. But given the injury occurrence that we continue to experience, clearly we have not identified all the horses for which withdrawal is warranted. Despite subjecting horses to higher levels of scrutiny than occur practically anywhere else in the world, the occurrence of race-related fatalities in North America remains exceptionally high and virtually unchanged. So we have a critical need to identify additional strategies for effective intervention. We talk an awful lot about medication, and the majority of my time is spent looking at drug testing results and trying to understand the impact of medication in the racing horse. And I think there's a huge ethical burden that comes along with the ability to administer medications. Just because you can doesn't mean you should. And every time someone contemplates medicating a horse, they need to weigh the benefits against the potential risk for modifying the horse's clinical presentation to result in the illusion of soundness. Not the reality of soundness, but the appearance of soundness. The illusion of soundness continues to be the single greatest challenge for the examining veterinarians in making determinations about whether or not a horse is fit to participate in a race on a given day. So my question is, are there medication usage patterns associated with increased risk? If so, what are they, and how can we address them and educate stakeholders to modify medication practices outside of the context of a race? So I look at what's called filters off results from our drug testing. And what that means is once drug testing is completed and final reports are issued, the laboratory provides me visibility on all of the therapeutic medications that were detected in a given post-race sample. So what you see in front of you, we're talking about the individual horse, but each line represents the drug testing results from an individual horse. So we've got 20 plus horses right here. The yellow shading represents, whoops, methylcarbamol shouldn't be in there, represents corticosteroids. The green shading represents NSAIDs, and a gray box means that that substance was detected in a horse's post-race sample at concentrations below regulatory threshold, so there are no medication violations here, okay? But this is giving us insight into medication usage patterns in individual horses. And the first time I looked at this, I got a little excited. I said, look right here, this horse has got 2 corticosteroids on board and 2 NSAIDs. The bottom horse has got 2 corticosteroids and 3 NSAIDs. No medication violations, but looking at it, my first thought was, boy, these horses must have problems. Somebody felt it necessary to get an awful lot of medication on board these horses. And then my good friend Scott Hay, who was here earlier today but chose not to stay because he heard I was going to mention his name, told me I was overthinking. And he said, no, you really need to sort this data by trainer, and it will tell a completely different story. And so I did. Whoop. We looked at those horses. These tables represent drug testing results from 4 different trainers in Kentucky. Don't worry. Can you see the gray boxes? It showed up better earlier. Can you see them or not? The fill-ins? Okay. So we've got 1, 2, 3, 4 trainers. These are all post-race samples. In some cases, a given horse may be represented more than once because it ran more than once during the interval that we looked at these. But what you can see up here, the trainer in the upper left-hand corner, we've got 1 gray box here, so 1 NSAID and 1 corticosteroid. No other medications present in these horses. Over here, every horse has got bute. We've got a little flunixin. We've got 1 horse with methylpred and 1 horse with, I can't even see what that says now. Methylcarbamol, okay. Bottom lower left, just about everybody's got both butanbanamine and 1 corticosteroid. And over here, you can see we've got an awful lot of medications on board. Now looking at that, there are a couple of things that trouble me and give me pause. The first one, oddly enough, is not the lower right-hand box. That's a whole other issue. But upper right and lower left, it appears that those trainers have programs, and these horses receive prescription medications as part of a standard routine. Do I think that every horse in this barn needs phenylbutazone prior to a race? Probably not. And in fact, in talking with trainers about their medication programs, many of them will say, well, I give bute, the horse didn't need it, but it's just what I do. So the concern about treating the horse as an individual and identifying the horse's individual needs, at least in the upper right-hand and lower left-hand columns, or upper right and lower left-hand tables, gives me some concern that perhaps these horses aren't getting individual assessments and aren't getting adjustments made based on their individual and hopefully unique needs. Lower right-hand box, my question here is, I don't know which of these horses are sound and which of these horses are unsound. I can't determine that from this volume of medication usage, but far more concerning is I don't believe the trainer can know which of these horses are sound and which of these horses are not. which have those pre-existing conditions that are going to shortly manifest as a catastrophic fracture. With this kind of medication load, with this kind of medication philosophy, I think there is a huge risk. One of the other things that we do is we do out-of-competition testing, predominantly on graded stakes horses. Now, when we do out-of-competition testing, we are specifically regulating blood doping substances. We go ahead and do a full instrumental screen to see what information we can learn in terms of medication usage patterns in the population outside of the context of a race. Now, the reason you see all these horses here is because when I received the out-of-competition results, I went ahead and I looked to see which of the horses had breezed the day that they were sampled. And all of the horses represented here breezed the day that they were sampled. And so what we see is a pretty high medication load. I think I've got these, so they highlight. The threshold for phenylbutazone, you recall, was 2 micrograms per ml in a post-race sample. This is 20. If this horse received phenylbutazone the day that he breezed prior to a breeze, the impact of that medication on that horse's performance and any musculoskeletal disorder that he may be experiencing is potentially very high. We've got a lot of, we've got triamcinolone and flunixin in one horse. We've got one horse that's got dexamethasone or betamethasone, a very high concentration, looks like a same-day administration, Vetalog, ketoprofen, and phenylbutazone, and again, the phenylbutazone is at 15. Now, when I was on the New York task force looking at racing fatalities, one of the things that we talked about was missed opportunities for intervention. And one of the things that the AAP talks about is having the opportunity to assess a horse's response to exercise. And I put it to you that when these medications are routinely administered prior to a breeze, there is a lost opportunity to understand the horse's response to high-speed exercise, to demonstrate those subtle signs associated with a pre-existing condition that can likely evolve into a catastrophic fracture if the sign of lameness, which isn't a disease but a sign, as Dr. Bramlage said, isn't recognized and acknowledged and responded to in an appropriate manner. You look down here at the 2 green rows. One horse had no medication on board, and the other horse had a very low concentration of either dexamethasone or betamethasone. I would put it to you that the trainer associated, or the trainers associated with those 2 samples, were very able to assess their horse's response to high-speed exercise and make a responsible decision about whether or not to pursue training the horse, whether to pursue racing in that graded stake. I have real concerns about the use of NSAIDs in conjunction with a work, but plenty of trainers do it. And the argument is it helps the horse cool out better. They bounce back better, they're ready to go back to the track, they feel better. It's the humane thing to do. And I would suggest that losing an opportunity to understand whether or not you have got the kind of orthopedic disease that can progress and cause the serious problems that can result in the complete loss of the horse or withdrawal from an extended period of time does not represent activity in the best interest of the horse. Finally, and this is an hour lecture and we don't have time for it, we noted that there were medication usages that varied on a per racetrack basis. And so that became a factor in how we assessed horses on a per meet basis, how we interpreted physical exam findings. There's an awful lot to talk about there, but it just shows how you can look at the data in different ways to understand what questions you need to ask when you look at a horse or you're engaged in an exam at either of these 2 meets. And finally, Dr. Romano is going to talk a little bit about her concerns related to the use of medication as it relates to the pre-race examination. And so on the left, we've got a grid that's got filters off from 2013, and you will see that almost all the horses had at least 1 NSAID on board, and there was an awful lot of corticosteroids at fairly high concentrations. All of them would represent medication violations according to the thresholds that are currently in place. And I think it's fair to say that the presence of those medications had the ability to modify the horse's presentation and obscure the veterinarian's ability to perform an effective pre-race examination. 2015, same racetrack, same month, same race meet, but a substantially different picture as far as medication usage and I think the ability of our veterinarians to intervene when appropriate, when the condition of the horse actually warrants it. And so for those of you who are regulators in racing jurisdictions, I would encourage you that this sort of information should be available to you from your laboratory, and it is well worth taking a look at it. Doesn't mean we have to regulate medications outside of competition. Doesn't mean that I'm saying medications are bad and shouldn't be used. What I'm saying is they need to be used responsibly and ethically, and if they are being used in such a way to make an individual feel better about how the horse looks, as opposed to understanding how the horse really is, that represents an at-risk behavior, and that is an educational opportunity that we can use to hopefully reduce the occurrence of fatalities that at this point we have been unable to effectively change. And so with that, I'd like you to keep these numbers in mind and the things that you've seen as you hear the comments from the other panelists, because I think it does tie in with some of the things that you're going to see from Dr. Kennedy in terms of what those lesions meant, who saw them, and how did they respond. So with that, I'll turn it over to Dr. Kennedy.
Okay, are we good with this? All right. So, like Mary said, I'm Laura Kennedy. I'm at the diagnostic lab here in Lexington. And I've been working on the racehorses since January of 2009 is when we really started. What was?
You can't hear you talk. Really
Okay, there we go. Sorry. So what I'm going to do in this talk, I'm going to talk briefly about the Kentucky program, how it evolved, how it's continuing to evolve, what we do at the moment, efforts that we're making at harmonization of necropsy programs throughout the country, and then some future things that we'd like to explore in Kentucky. So like we've heard earlier in the morning, obviously there was a lot of attention to catastrophic injuries in 2006 and 2008 with 8 Bells and Barbaro. And then in Kentucky, we also had an unusually high number of fatalities. At Turfway in December, it was very unexpected, and we decided maybe we need to start looking at these things a lot closer, and Dr. Scollay was really the person to generate this program. Prior to 2008, it was just a simple documentation of the injury. Yep, this is what was broken, you were right, and there we go. Here's a report of it. Only racing injuries were documented. However, I do really want to address Keeneland and to really, it's very admirable what Keeneland has done from the very beginning. And before there was a necropsy program, Keeneland management always submitted all of their horses. Even when outside of the meet, if they had a training death, the horse was taken to the diagnostic lab, Keeneland paid for the necropsy. So they've been believing in this for a long time. So like I said, from 2008, when we started, through 2012, we were doing just racing fatalities, and that could either be musculoskeletal or non-musculoskeletal. We did a detailed documentation of the injury. We did examine the contralateral limb, maybe not in the detail that we do now. So as we're going through the presentations, we're talking about pre-existing lesions and the fact that, like Dr. Bramlage said, 90% of these horses have pre-existing lesions. And we'll see that pathology is symmetric and that probably the opposite limb, the contralateral, is the most important. Starting in the spring of 2012, we did all fatalities, which would include racing and training breakdowns, as well as non-breakdown deaths that occurred at the track, horses that might have colic or pneumonia, laminitis. Those horses would come to us as well. And those are a very useful control population we'll talk about. I've been doing very detailed reports. Finally this year, I think I developed a better way to do it that's a lot easier. It only took me 5 years. So the way that our necropsy program works is at the time of the death of the horse becomes the property of the racing commission. A unique identifier is put on the horse, usually their tattoo. They are then shipped to the laboratory, generally by a contractor. They come to the lab. But even before they get to the lab, communication has been established with the racing commission and the laboratory. We have a special accession sheet for the racehorses that's in the program book. To make it easier for the veterinarians, this is a fillable PDF. They have it with them on their laptops at the track. Most of these are drop-down boxes, so you can get all of the information very quickly, very easily. And then there's also a part for their comments. This has really helped us because, you know, when something happens, you're not thinking about everything you need to write down, but if it's there on a form in front of you, it's a lot easier to do. It's very standardized. This gets emailed to the diagnostic lab and to the pathologists that are involved. When the horse comes to the laboratory, we do a standard gross examination of the horse. So we look at the carcass as we would with any other necropsy, examining all the internal organs. Then when we get to the limbs, we will take the affected limb and the contralateral, so the affected limb and the opposite limb. Those limbs will be safe backed. Dr. Scollay will do digital radiography of those, which not every lab has the capacity to do, and that's okay. Then I'm going to do a detailed documentation of the injury itself, and then I'm going to look at the contralateral limb and do a very detailed examination of the contralateral limb. So when you're looking at the fractured limb, there's a lot of artifact at the injury, something that happens at the time of the fracture, and it's going to obscure a lot of the pre-existing pathology. However, all of that is going to be visible in the contralateral limb. So fracture sites are consistent, the patterns are consistent in the different types of fractures, pre-existing pathology is consistent for the particular fractures, and it's symmetric. And I'm just going to go through very briefly just a few examples. Our condylar fractures, which, as we talked about before, are some of the most common, have a very specific pattern for a lateral condylar fracture and a very specific pattern for a medial condylar fracture. And I'm not going to spend much time on this, but so this is a lateral condylar fracture. So you're looking at the cannon bone, distal end of it. This is where the fracture, so there's a fractured piece, and it's about 9 centimeters long. And so this picture really illustrates why I need to look at the opposite limb, because there's been a lot of damage to this limb artifactually, and there are a lot of things that I can't see on this limb that might have been there previously. Another, a medial condylar fracture, very characteristic. This time you're looking, it's as if you're looking at the back of the horse, starts in the medial condyle and then spirals up the bone so it crosses midline and goes all the way up. But the important thing is the pre-existing pathology. And again, that's something that we're going to see much more clearly on the opposite limb at the time of necropsy. So we have a number of lesions that we look at, including lesions that are in the parasagittal groove, which I'll show you, on the transverse ridge, and then we're going to get to something that Dr. Bramlage mentioned. This slide, I think, is very illustrative. This is why it works, because when you look at this, you have this circular lesion here and one there. This horse, these are forelimbs from a horse that had a hind limb fracture. But this illustrates, you can see this bone lesion here. This is a subchondral lesion. And the other one is right here. You have lines in the parasagittal groove, scoring lines, and they're exactly the same on the other side. So this is why, because it is so symmetric, this is why the opposite limb is what I need to look at. So this is the medial condylar fracture again. So there's the fracture line. And so this is the medial condyle of the opposite limb. And so then there's that same, essentially, stress fracture. So this lesion was also here, but on that particular limb, it resulted in a catastrophic fracture. But, so you can see the pre-existing pathology right here. And there have been plenty of studies. Like we said, Sue Stover has been doing this for 25 years. It's very well established. And again, this is just another look at one. So these are the bone bruises that Dr. Bramlage was talking about. You have this dark discolored area, which then extends into the bone. So you have this area of hemorrhage, but then this darker, or this brighter white, that's the sclerotic bone. That's the bone that's too dense. This is as bad as you can get for buck shins. When we talk about microfractures, like Dr. Bramlage talked about, there's a point to which you can push a horse in order to get the reparative response, then you can push them too far. And again, these lesions are fairly symmetric, so you can see them on both bones. And then here you have a very severe lesion. This horse had a fracture on the opposite limb, which looked like this. So these are the two limbs. You have bowing here and a lot of hemorrhage. And then this is the affected limb. So once again, I can't get very much information at all from this affected limb. There's too much artifactual damage, but I get all the information I need from the, quote, non-affected limb. So I mentioned that we have a real advantage in getting some of the non-musculoskeletal death horses. These are our control horses. So this is any horse that dies on the premises, and so this gives you a population of horses that is in active training or racing, exposed to the same environment as our horses that suffer catastrophic injuries. And we can look at that and see what our population of horses is, and evaluate where, try to look at some of these horses and say, where do you draw the line? And you can't draw a line. This is a filly that died of pleuropneumonia. You can see she has some subtle changes, which you expect with training. But so this is a horse that's out there working with minimal pathology. There's pathology there because she's in training. And then we have a horse here. This is a horse that was in an accident in the starting gate. He was very reluctant to load. He flipped over, he got his leg caught, and he had to be euthanized. And this horse is not, so this horse doesn't get classified as a breakdown, but you can see he's got basically a hole in the cartilage here, and he's got a lot of pathology. So this might be one of those horses that maybe somebody isn't listening to him. He knows that he doesn't want to race, perhaps. So in my exam, I try to do a very thorough exam, and you have you have a redacted report. But what I'm trying to do now is to develop a system that is a little more objective, a little easier to use, easier to input the data into any type of database. So again, you have an example of this in your book. This is basically my report. I do a detailed description of the fracture, but then the associated lesions I put scores on, so that when you compare horses using a numerical system, makes them a little more objective. So So like I said, these scoring systems can be applied to all of our horses, whether they're musculoskeletal or non-musculoskeletal horses. There are peer-reviewed references for this system, and we can use those as data points, entry into systems. And a scoring system is great, but the thing that is also very, very important is I do photo documentation, because when you are doing a mortality review, like Dan is going to talk about, and you're trying to address a problem with a trainer and say, okay, this is what was going on with the horse. Numbers are great to input into our spreadsheets, but the photographs are what are really going to help you. So when I'm doing my exam, I'm really thinking about the end user, because the end user is both Dr. Scollay using it in a database, and also someone talking to the trainer and saying, here, look at this. Let me just show you. So you really have to, decide. You have two audiences. So what I'm trying to do now is that there are many, many diagnostic laboratories that are being asked to do post-mortem exams. Like I said, in California, they've been doing these exams for 25 years. In Texas, they're just starting. Other places, it's very scattered. There's very little communication between the laboratories that do that. In fact, a lot of times you don't even know. You're like, oh, I didn't know they did in Colorado. So we're trying to develop a working group to kind of standardize things, get all the information, and see if we can't harvest the data as much as we can. One of the problems has always been is that many laboratories are asked to just to do the exam, and people feel like it's something that's, it's either terribly obvious. They say, well, why do I need to do a racehorse necropsy? You know why it died. Or the pathologist may say, there's no way I can do the kind of work that Sue Stover does. Why do you want me to look at it? And that's really not what we need. What we need are detailed exams and a minimum database from all of these racehorses, which is not rocket science, or I wouldn't be able to do it. It's just a very thorough, very well documented exam. And that's one of the things that, as we're going to different meetings and kind of getting a working group together to really communicate to people to other pathologists that, this really isn't hard. It's detailed, it takes a lot of patience, but it's not a difficult thing as far as capabilities. If you're a capable pathologist, you can do this. And I think there are a lot of pathologists that would be very happy to have the information, have guidelines. So that's what I'm trying to do, trying to harmonize it a little bit. So looking forward, obviously trying to harmonize the programs, a little more uniformity. One of the things we're looking at in Kentucky, and Dr. Romano's looking at doing it too, is being able to look at a particular horse start to finish. However, we may be, a lot of times people think that pathologists are too late. Maybe we're too late for one horse, but what we really need to focus on is the population. Dr. Jamie McLeod's here, and we've got a good group of people between the diagnostic lab, the Racing Commission, and the Gluck Equine Research Center. We're going to develop a sports medicine working group, which should be very interesting. So one of the things that Mary asked me to talk about, just to briefly mention, if there was anything that kind of surprises me about these programs, and what surprises me is the information has been out there for so long about pre-existing lesions, but we don't seem to be effectively getting the information disseminated, or somehow people still believe that a horse simply takes a bad step. And if they're going to take a bad step and that's what's going to happen, I can't prevent it. but we need to, and again, it's just surprising how much we still hear that. And that's where I hope the information that I give people, that I give to Mary or to Megan, that we can, the education can go further. But that's pretty much. That's what I do with dead horses. I really believe in this program. We've made a lot of progress, and you know, it's very important. It's very important for the horse. That's pretty much it.
Come in, Albuquerque. Okay. We have that. What I was asked to talk about is what is being done with this information. And over the last 5.5 years, I've been working at various racetracks as a steward and a director of racing. And today I'm here on behalf of the Racing Officials Accreditation Program to talk about what the stewards are trying to do with this situation. And each year we put out recommended points of emphasis for the racing commissions, for the stewards, and for what's taught at the continuing education programs that our stewards have to go through each year. And this year, catastrophic injury review protocols is one of our recommendation. And as you've just learned, there's a tremendous potential here to learn from the catastrophic review, and especially from the necropsy report. One of the keys, though, is first, everything has to be done in the equine injury database, so you have the database as a resource. And when we say everything, we're talking about not just catastrophic injuries or equine injuries, not just race day, but training, basically anything that involves an injury or an illness to a racehorse where a regulatory veterinarian's involved. Build your database for you so you've got something to go to look at this horse's history. And then obviously you got to have a necropsy program. We don't know exactly how many states are using it on a regular basis, but we think about half have necropsy programs. And it's going to be essential, as Dr. Kennedy said, that we get these necropsy programs doing it on the same basis, so we've got comparable information to compare from one jurisdiction to the next. And what we recommend is there be a catastrophic review committee at each racetrack that will go over what happened in this particular breakdown, this catastrophic breakdown, but also could be going over a rash of soft tissue injuries, or the veterinarians are complaining and the trainers, my horses are coming back sore this last week. So you've got a committee that can deal with this. At some tracks, they've started a safety committee, could very well assume the responsibilities of this committee. And the one point I want to make is this is a fact-finding effort. It's problem-solving. You're trying to eliminate the different factors so you can zero in on what may be a cause or may be the causes. We're not trying to find fault. This isn't an inquisition. There's not going to be penalties assessed to the trainers or whoever might be involved. It's so that going in the future we can start eliminating the injuries, the catastrophic injuries, and maybe get our rate down like we've tried to do for the last 9 years. Who's on this? Obviously the veterinarians, regulatory track, the board of stewards, whoever's responsible for your racing operations, whether it's the general manager, director of racing, or the racing secretary, absolutely the track superintendent. And then as we've developed this, predominantly when I was in Massachusetts working with Dr. Jen Durenberger as the executive director of racing for that commission, representatives from the different groups, the practicing veterinarians, the Jocks Guild rep, and the Horsemen's Association rep, because they all have a vested interest, obviously. And what are we looking at? It looks fairly simple when you talk about this information, but it takes some advanced planning to get it collected properly, especially with race video replay. Those of you that have gone back to look at race video replays on catastrophic injuries, the horse was trailing the field when he went down and he wasn't in the video. They were focused on the front runners. The horse goes down after the race in the turn. They are following the winner in the turn, not the horse that went down. So you've got to work with them, and there'll be times when you don't get it on video. But if you're working closely with your TV department, they can expand the coverage of what they do so that you perhaps in most occasions can get the video and hopefully on more than one camera. Past performance information in the race charts is easy to pull off the Encompass RTO system or Equibase. The equine injury report data and the EID history on that horse. If your track's doing it, you got it. Daily veterinary medication reports. It's been my limited experience that this is required in most jurisdictions. It's a model rule. Is it collected on a daily basis? Maybe. Is it gone over on a regular basis? Maybe. If you don't do this, you're not going to have that available if you don't collect it on a routine basis. Radiographs of that horse, if there's available. There is the question of, do you have the right to have access to the veterinary medical information, and sometimes you have to request it. Some trainers keep great training records. Others don't, but they will tell you a lot as far as what he's doing with this horse on a day-to-day basis. We've heard Dr. Peterson talk about track maintenance records. They're absolutely essential to see what was the condition of your racetrack on the day that that catastrophic injury happened. And is there some sort of correlation possibly, or can you eliminate the track surface from one of the variables? The drug test from the lab, I'm surprised in some catastrophic injuries, they don't do any testing on the blood or urine samples because, well, they're hard to get. We've euthanized this horse. You can still do that at the lab level, and you can still send them off for drug testing. Pre-race exam findings are absolutely essential. The insurance status of the horse is just good to know. I don't know that it's a factor, hopefully not. And then we do interviews with the trainer, the owner, the jockey, or if it was an exercise rider in a morning training accident. If the horse just changed hands off of a claim, it's his first time back, or the horse just changed hands off of a sale, you might go back 30 days and talk to the previous connections. Again, this isn't an inquisition. This is, they know the horse better than anybody because they're the ones that have been taking care of it on a daily basis. And they care about what happened to that horse. And every time we've done this where I've been involved, they are more than willing to give you an interview and tell you what they've done. And you get some information. I had one trainer tell me one time that, I will never train a horse with this type of confirmation again. He said, my dad bred this horse. I told him he shouldn't breed that mare. She was a hard-knocking racehorse, but she had some confirmation problems. The resultant foal had some confirmation problems. We put her into training. She's been in training for about 4 months, and this happens before she ever goes to her first race. So you find out interesting things when you sit down and go through and you may find a solution. I went backwards. Somebody's got to be responsible for doing this, or it won't get done on a routine, regular basis, and it'll get away from you. Hopefully you're not doing it very often, but somebody's got to be responsible to collect all this information and then get it to the committee members long enough in advance before you have the committee meeting so that they know what they're talking about. They don't just sit down and start reading it. They've had a chance to review it and go over it. And then when the report comes back from the lab, you've got enough time to give it to them for a couple days. That's when the meeting needs to happen. Again, as soon as possible, because you may discover, this is what's causing it, or this may be something that we can prevent in the future by changing something we're doing either in the training, veterinary practice, track surfaces, how the starter operates the starting gate. You may find something, so the sooner you do this, the more important it is. And then, again, the recommendations that you get are what you can carry forward. We had a situation at one track I was at where we had a number of 2-year-old quarter horses that were going down after the race in the turn. And we came back with Perhaps the track was a little too deep in the turn. We might firm it up. The jocks, because it was a short run to the turn, were standing up too quickly perhaps and causing the horse to adjust for the sudden change in balance. Talk to the jocks. Radiographs. This was a first half of the year type meet. Were the knees closed? Or maybe we should pay more attention like we used to in the past and hopefully still do. You know, were the knees closed enough? Certainly you can put the horse in training, but were they closed enough for you to be racing this horse? So when I found out I was speaking, I said, well, I wonder what's happening in other jurisdictions with this type of review. So we did a quick survey a couple of weeks ago and got 24 responses, and this was a survey that went to stewards. And we think there's about 18 jurisdictions that responded. Some jurisdictions we had more than one steward respond. And do they have a euthanasia post-mortem necropsy examination program? 19 of them did, 5 didn't. Where'd they go? Mostly to a vet school. In one state, it went to the state animal health laboratories, but predominantly they're going to a veterinarian school. Did they pull samples? Yes, they did pull samples for drug testing. Do you have a standard protocol to review it? And we left a space for comments after each one of these questions. If you said yes, what? And this is where there was some variability as to who was involved and to what degree this program was carried out. And as you can see, we asked who was involved. It's predominantly, as you look at this, a veterinarian run or motivated situation in most jurisdictions. The regulatory vets, the track vets are there, and the practicing vets are well represented. Track management wasn't as well represented as I would like to have seen, and the track superintendent only worked in 5 of these 18 or 19 protocols. What were they collecting? Well, obviously the necropsy report, but not all of them were collecting necropsy reports because maybe they didn't have a necropsy program. Pre-race exam findings, the videos, drug testing, there was the main ones that were there, but wasn't there was the trainer's records and track maintenance records. And again, this is a very important aspect of the protocols. And has there been, a benefit in doing this process? And 7 said yes, 5 said no, and 10 said to be to determined later. And I think that was my experience in doing this was we've got to do this over a several year period and do it right and do it consistently before we're going to start seeing long-term benefits. Then the question is, if your racetrack doesn't have this protocol, would you like to see them have it? And obviously the vast majority, only one steward said no. They would certainly like to see it happen. So I think it's something that this industry can do. It's not extremely difficult. You just have to take the time, have the commitment, and make the effort to do it. Oops.
Hello. All right, so I'm basically just going to tie everything together. I feel like a lot of what I got to say has been touched on by some other folks today, which is great. First off, just like to kind of give some background on what we do at the Kentucky Horse Racing Commission in terms of understanding the overall health of our population of racehorses. We do a lot of what Dr. Parkin already mentioned with the risk factors that have been identified. We pull the PPs as they become available. We'll review them for any of those red flags that he mentioned as far as risk factors. When they warrant, we'll actually come a day or so before the horse is actually entered to race and do a non-race day examination, see if we can at least look at the horse one extra time besides on race day. Then we do our race day exams, try to gather any other intelligence that we can about a horse that's had anything of concern in those PPs. And then we do our on-track assessment, watching the horses in the post-parade and the warm-up. And then again, if it warrants some of those horses, we will follow up after the race, after giving some time to cool out. So again, it's already been mentioned, some of these risk factors on paper: sharp class drops, multiple claims in a short time span, having a long layoff or several short layoffs, poor performance, being eased, vanned off in the recent history. All of those will kind of flag and give those horses some extra scrutiny. So a lot of the time, the extra concerns are these horses with very long layoffs. So those are the ones we'll go to the barn prior to race day, try to find out from the trainer what's been going on with this critter, why has it been off, how long has it been back in training, how well has it been training. Just try to paint a more complete picture of what's going on with that animal. The more information that we can gather, the more comfortable we are letting the horse race. And a really good example of that is just this past meet at Churchill. 2 different horses that I looked at, both were in this category. It had quite a bit of time off. The first trainer, when I inquired, said, "Oh, yeah, doc, that horse had a condylar fracture repaired on, such and such time frame, was off here, returned to training," was very forthcoming, we got the whole picture. He's on top of it, he knows what's going on with his horse. Now we know, everybody's happy. Trainer 2, in a very similar situation, when I inquired, looked right at me and said, "Well, doc, he had a bit of a boo-boo, so we thought we'd turn him out." Now, does he not know? Is he being shady? We don't really know, and that makes us very nervous. So, again, just try and get as much information as we can. Our race day examinations, so we make sure we're looking at the right horse, age, sex, lip tattoo, all match. Some of the really horrible ones, we have to go by markings, which we have all available. Look the horse over, general body condition, posture, attitude. Both forelimbs are palpated, both standing and non-weight bearing. The knees and fetlocks are flexed. And then the horse is jogged in hand away from and then back toward the examiner. And all of this is recorded. We use the Encompass exam module, which lets us then go back and compare not only what we have, but anybody else that's also using that. We can look and see, here's what the horse looks like today. How does that compare to how he looked last time he raced? Things like that. So before we go onto the track, we sit down, we go over our watch horses. These are horses that had those red flags on the PPs. They may have a minor gait abnormality. Maybe they were a little stiff, a little choppy, things like that, just to watch and make sure that they warm up appropriately. Any new changes, again, comparing to exams previous, how does that compare with today? And then we try to look at everybody thoroughly, but especially these that we flagged as watch horses during the post-parade. Post-race follow-up, if we have horses that maybe they came back for unsaddling, maybe we're not sure if it's completely saddled, looked like it took a couple of bad steps. Lame horses are a whole different story. Those will get, very lame horses will get banned off. But if they're kind of so-so, we'll wait 15, 20 minutes, let the horse cool out, see if the horse is actually okay. Maybe he was just tired, took a bad step when he down transitioned, or if it's actually lame. That gives us kind of time to figure that out. So we'll jog it again, may or may not palpate and flex. So then we also kind of conduct our own in-house mortality review when we have racing injuries, where we go back over a lot of what Dan mentioned, the information that we have, our exam findings, the PP, the horse's history, how the horse warmed up on the track. Again, trying to identify any opportunities that maybe, should have been seized, and could we have intervened? Because everything that we can do to identify an area to improve our protocols is going to improve the horse's safety and the rider's too. So limitations of what we do, and we do a lot, but we're constrained by time. Obviously, even those cases where we flag a horse's PPs and then we go back and look at them before they race, day of race, after they race, we're still seeing snapshots. It's not a video, and it may be 2 or 3 snapshots, but it's still, we're not in the barn every day, we're not watching the horse train every day. We have one little window to make an assessment. And then as Dr. Scollay talked about medication variation, we don't know. She showed those slides, you know, the horses that had maybe 1 or no medications on board versus the one that had everything in the truck. We don't know who's who. We don't know if this horse looks sound. Is he really, or is he being helped? And then, you know, we have our digits. We do a digital exam only, and we have eyes, we have fingers. We're not doing x-rays, we're not doing ultrasound. In some cases we will if we have a question and we feel that, you know, that horse raises a concern and we're not going to let it race unless you x-ray it and show us that's okay. That does happen occasionally, but generally, you know, we're going off what we see and what we can feel. So initially, I started attending the postmortems to improve what I do on a daily basis at the track in a couple of ways. So it's quite one thing to palpate a limb. You can feel some things are thick, some things are enlarged. And we try and make our best clinical assessment what's going on in there. But I thought, how much better would that be if I could take this opportunity, do the same thing to these horses that have suffered these injuries, and then attend the dissection, really look inside, really get a good idea what exactly is going on. It doesn't change, because we already do such a thorough exam, it didn't change at all my exam procedure, but I've definitely become more consistent in recording the findings and really knowing what to call different things that are palpable in the standing horse. So a couple of unexpected lessons, and I know, you know, we've talked about Sue Stover's work and how long it's been out there, and it's, even for me, I mean, it's something I've heard about. I've gone to AEP, gone to North American, heard talks. It still didn't prepare me for actually looking inside those legs and going, wow, there's really stuff going on in here. So the bone bruising, the palmar osteochondral disease, and Dr. Kennedy's pretty well covered this. You know, it's there. I don't know how there's still any debate and how the oh, we just took a bad step is still even a thing, but I do think that part of what I really learned, sort of going to some of the talks that discussed it, is the limitations of radiology versus scintigraphy versus MRI to identify what's going on in these horses. And I would sort of submit that Dr. Bramlage is just a tad spoiled in the images that he gets to look at, because Sherry Miller takes the best flex lateral. And she brought me to tears a few times, but she taught me to do it too. But when you're looking for something as subtle as flattening of the condyles, they have to be perfect. And I've seen, you know, what we used to kind of pass at the, oh, that's close enough. You know, that'll work. Even with digital radiography where you can see it right then. And my old boss used to drive me crazy. Oh, that's fine. No, it's not fine. You can't see anything. And I'm definitely not going to take that over to Dr. Brownledge and ask him to look at it because he knows he taught me better. But again, just the actual seeing these limbs just kind of really brought it out of a CE in the lab sort of context and into real life. And because of that, because of how symmetric these lesions are, going back and then looking at our exam findings after being in the lab, seeing the legs, seeing the mirror image, one of the striking things is that a lot of these horses, you know, we look, if we're making a decision on a horse's racing soundness, a lot of what we're looking at is, does he jog okay? Is he even? You know, is he limping? Is not good. These horses, a lot of the time, don't, because they're sore on both. And they may be choppy, they may be stiff, but so are a lot of other things. This is hardly pathognomonic for bone bruising. Horses with arthritis are choppy and stiff. So that was both kind of a surprise and I think a challenge for us that, again, we're looking at the horse at the snapshot in time, and we need it to be a team effort with the trainers, with the private veterinarians who are in the stalls that know the horses better, that maybe we can have conversations with and hopefully find out what's really going on with this horse and, again, paint a more complete picture. So the silver lining, and Dr. Arthur mentioned this too, it's a good thing that we know that injuries don't just randomly occur. I guess the temporary sort of nobody wants to feel like they missed an opportunity. That had they done something different, maybe this horse wouldn't have been injured. I was examining horses in New York the horrific year that we had in 2012 when Dr. Scollay and Dr. Palmer and others came and did the task force. And I know for me, the first thing reading it and seeing under a horse's name, yes, there was probably an opportunity missed. I mean, the first reaction is, oh my God, you know, you feel so bad. Nobody wants to lose a horse. Nobody wants the horse that they examined to be the one that broke down. Nobody wants to feel like they missed an opportunity. And so on the one hand, you can sort of duck the responsibility if you, oh, it was just random, you know, nothing I could have done about that. Well, that may make you feel better for a minute, but in that case, if we can't predict it, we can't improve, we got nowhere to go with that. This is a good thing. Opportunities for intervention means that there is room for improvement. There are steps that we can take. And I think the big thing now is communication, the CE. Again, I've had a few conversations with some of the private vets on the backside. Again, they've been to the talks, they've seen the MR. When I've mentioned that I've been going to the lab, this is what we're seeing, this is what we're finding, they've been pretty surprised too. And the other striking thing for me is looking at these horses, looking at the exam records where they were stiff, choppy, etc. When I was in practice, if we had a horse that was stiff, had some fill in the ankles, we would take pictures of the ankles. No obvious abnormality, no chip, no hairline fracture, you know, nothing obvious going on that would cause that horse to be lame. So we think, okay, well, it's probably synovitis, capsulitis. We're safe to inject. And in hindsight, you know, I worry about how many of these horses had that maybe I injected and maybe they had this process going on, and how many people are still doing it, and how many people don't, not because they don't care about the horse, just because they don't know. And so I feel like I've already been able to share some with the private vets just in conversation. And then conversations with trainers, we talk about CE for trainers, and I think we just need to start with some plain old E before we get to continuing, because a lot of times there's just nowhere to go if they don't at least have a little bit of background and at least understand some of these things. So I really think those efforts are going to be key to getting the education out there, getting the information out there, communication and teamwork, and realizing that we're all here for the same thing. We need to take care of the horses. They take care of us. And so, again, Dan went over the mortality review. It's an educational opportunity. Nobody's trying to point fingers or assign blame, but it is a terrible situation because it means that we have lost a horse. And how much better would it be if we could educate and get this out there before it comes to a catastrophic injury? So the next step, how do we find these horses? Completing the picture, again, communicating, figuring out how to separate the osteoarthritis from the bone bruising, from we can't all afford to go in for MRI and bone scans, unfortunately. And then if we find them, what's the appropriate course of action? And Dr. Bramlage already touched on that too, about time off, which, again, from my time in practice, that was one of the most difficult things to convince people to do often, is just giving a horse time. And helping them understand there is nothing in the truck that's going to fix that without giving them time. And that's true for a lot of disease processes. So where to go from here? I don't have all the answers. I mostly have questions. But I do know that it needs to be a collaborative effort. We got a lot of ways to go still, but we're definitely on the right track. And every time I've been to this conference, it gets better and better. I feel like we're slowly getting there, and we're going the right direction, but we're not there yet. So,
Okay, thank you. And it looks like we've hit the deadline, so we don't have time for questions. Thank you all for your attention.
Yes, I want to remind members of the Grace and Jockey Club Foundation, if you're a member, please attend our meeting, which will be, there's a separate entrance over there with the sign, so I really hope you will join us. And now I'd like to thank Donna Brothers for doing a great job.
Thank you, Ed. So one of the things that struck me from all this is that so much of this research is difficult and some of it seems impossible. Right now I'm reading a really good book called The Slight Edge, and in there was a quote that I thought was really appropriate for today, so I'm going to leave you with that quote. It's from Norwegian explorer Fridtjof Nansen. He was awarded the Nobel Peace Prize in 1922 for an extraordinary act of heroism. Here's what he had to offer on the subject of impossible. Quote, "The difficult is what takes a little time. The impossible is what takes a little longer." So yes, it takes time, and thank you. And Dr. Scollay, I'm sorry that you didn't get your result of a 50% decrease in 10 years, but I think with time you will get there. So thank you to all of the veterinarians here today, the researchers, racetrack superintendents, racing officials, track owners and operators, and last but not least, of course, the Grace and Jockey Club Research Foundation for all the work that they're doing. Thank you for putting in the time it takes to make improvements in all of the areas discussed today, because eventually, with time, we will be able to achieve the impossible. Thank you.
Thanks again, and I would like to also thank the media. I really appreciate your interest, and thank you all for coming, and see you soon, I hope.